Good afternoon. Welcome to today's afternoon session. On behalf of SOHO and MLI, I want to thank you for attending this half-day pre-session workshop entitled The Evolving Landscape of Anemia in MDS and MPN, Clinical Updates and Best Practices. This activity is supported by independent educational grants from Bristol Myers Squibb, BMS, Geron, and GSK, so multiple sponsors. I'm John Mascarenhas from the Tisch Cancer Institute at Mount Sinai in New York City. I'm really thrilled and honored to be joined by a colleague and friend, Guillermo Garcia-Manero, who's coming straight from here, Division of Cancer Medicine at MD Anderson. And we did a similar program. This really is a product of a similar program we did in Amsterdam last year. Although this is slightly different, I'm not entirely sure how this is going to go, but it'll be fun nevertheless. We have an exceptional panel here today, and I'll try my best to read off the list of faculty that we have with us, starting from left to right: Dr. Bose, Dr. Gerds, Dr. Camachi, Dr. Santini, Dr. Dezern, Dr. Della Porta, Dr. Palandri, Dr. Ulmer, Dr. Yenu, Dr. Noria, and I think we're missing Dr. Knafelmacher, right? Yeah, but we do have Dr. Lagavi, importantly, at the end. So before we get started, a few quick housekeeping notes for you. So throughout the presentation, there will be polling and assessment questions. This is really important. So please join us in answering them. So the first thing I'm going to ask everyone to do, please do this, is download on your phone the app that is called Soho365. Sorry, guys, tell me what the app's name is.
365.
365. Download Soho 365. Importantly, if you haven't already done it, because we're going to ask you to fill out the questions, the pre-session questions, ask questions during the program, which can be done also with the cards that are on the table. So please don't feel shy to write a question to any of the panelists today. So if you think of any question at any point, please put them into the Q&A polling questions, to fill out the polling questions, or on the cards, and they'll be collected at some point. And then we'll try to answer the Q&As at the end of the open mic before the dinner break. Also at your table, you'll find the QR code to download the slides and claim credit. This is CME accredited at the conclusion of this workshop. And once you complete the evaluation, you'll be prompted to download your certification for CE credit. So today, the 14, maybe 13 of us, we will engage in an exciting and forward-looking discussion on anemia in patients with MDS and MPN. I think that's the key part here. It's not one disease, it's multiple diseases, it's a spectrum of diseases. I think this makes it fun because we have representation from pathology, from transfusion medicine, from other disciplines, and people who have focused both on the MDS side, MPN side, and in some cases, the overlaps. The agenda for today will be the burden of anemia in MDS and MPN, then the diagnostic and prognostic challenges in anemia associated with MDS and MPN, game-changing therapies and personalized anemia management in lower-risk MDS, game-changing therapies and personalized anemia management in MPNs, and then we'll have a break to get dinner, followed by an expert roundtable multidisciplinary care discussion, and then the open mic Q&A with faculty. So I want to again thank everyone in the room for joining us today, and Guillermo and I will get started with the first part of today's meeting. So thank you for joining us.
Thank you. So it's actually a great opportunity for me here to be with Dr. Mascarenhas, who is only top MPN investigator in the world, but also a close friend. So it's always a lot of fun to interact with you. And it's true that last year we had this meeting in Amsterdam, and we thought it was kind of a great opportunity. And then somehow we said, why we couldn't do something similar around SOHO? This is really fantastic international meeting. We'll get together. It's like why we cannot start the afternoon before. So I'm extremely happy that you're taking a little bit extra time to come here in the afternoon. And then thematically, I think this is actually perhaps a way to approach these problems, where anemia does not only affect MDS, of course affects many other conditions. And I believe that there are probably some commonalities between MDS and MPN that cross disease entities. So I think we need to start thinking a little bit that way. Let me give you another example. It would be nice to have a meeting like this for p53 mutated disease, right, and so forth. So we need to start thinking about in a transversal way and see how can we affect diseases, not just from the side of the disease itself, but so potentially molecular mechanisms or or issues specific for a disease that may cross into others. So I'm very, very excited about this opportunity, and I'm actually very grateful to SOHO organizers for putting all this together, and actually to the sponsors that actually are making this happen. So thank you very much for the opportunity. So we're going to start with this. I think there is a polling, and I think you should have, right, the SOHO. Is that what were you saying, John? I got distracted for a second.
Please download the app and please answer these questions. It helps us understand our goals here.
So the question is, how confident are you in your ability to manage anemia in your patients with MDS and MPN? Super, maybe, somewhat, slightly, not at all. Okay, 0 is, right, because you're at SOHO. Everybody is confident. Is this working? Because it says the site can provide communication. Okay. Okay, so not confident, that's fine. But I like that we're a little bit modest because I agree we are not completely confident either, so if I'm reading this correct. So most of us are experts and we're here at SOHO, but even that, we think that this is actually not that straightforward, right? Beautiful. This is actually really interesting. I guess they're still voting, John, or? Okay, so before we go into the video, I think we decide to have, right, a patient. I think this is one of Dr. Mascarenhas' patient who's going to describe from their own perspective as individual with this condition, how they perceive and suffer this. So if we let Mr. Sheldon Wayman speak.
Anemia was just a word to me because when I had polycythemia vera, I didn't feel any symptoms from anemia. In December 98, when I first was diagnosed with polycythemia vera, I had like red patches on my face, extreme itching episodes. I'd be rolling on the floor. But over time, it switched to MF at the end of 2023. And at that time, everything went full circle. There was no more patches on my face. I was white as a ghost. I was really pale. And I was tired. It's the major contribution I like to offer to hematologists, to oncologists, and all patients suffering from MF. It's challenging, and I find, the balance is really difficult. However, it's really important to find and understand that this disease can be managed using a combination of medical treatments and quality of life wellness techniques. You have to find the balance. You can't just say that, today I'm out of it. I'm not going to do anything. You have to come up and adapt. When your hemoglobin is really low, what am I going to do, to make sure that I can move ahead? It's all about being fluid, flexible, and being able to adapt. What advice would I give to other patients, people who have this? Stay focused. You can live with this disease. And I'm going to say that again, that you can live with this disease. You just have to work on your quality of life and believe. It's also important to understand that doctors are constantly coming up with new trials. They're looking at existing drugs, supplemental ways to attack disease. And it's rewarding because these solutions keep my energy up. And I hope it will keep yours up as well.
So So just to give you some context about Sheldon, who's not here but made that video. So Sheldon is, I think, an interesting example of someone who had the opposite issue, which we're discussing today, of anemia. Had polycythemia vera, actually, initially. Too much red cells, needed phlebotomy, and had a whole host of issues, clinical issues that surrounded having overproduction of red cells, and then developed, which is not uncommon, myelofibrosis, and now has the exact opposite problem. Instead of being in the infusion suite getting therapeutic phlebotomy, he's getting transfusions. In fact, this gentleman is getting transfusions every week, red cells and platelets, unfortunately, and has undergone several therapeutic approaches to try to alleviate the anemia, which has not been successful, which is, I think, part of the reason why we're having this symposium. Because anemia is complex, particularly in these patients, the molecular mechanisms covering anemia and the therapies that we provide have to be tailored and unfortunately are not always effective. And he's a great example of that. And he suffers dramatically because his quality of life, he's a professor, his quality of life is totally affected by this because he can't teach in front of an audience anymore. He's tied into the transfusion suite. It governs his entire life. So I was grateful that he took the opportunity and wanted to actually speak about his experience of a patient with anemia. And we put that in there specifically to point out the fact that we're going to spend a lot of time talking about the biology, a lot of the clinical aspects. But at the end of the day, it's really about these patients and their burden that they have to carry from anemia, transfusion dependence, and all the complications that ensue. So the next question is, think of a transfusion-dependent patient with MF and anemia. How many hours do you think they spend on hospital visits? And I think this exercise is supposed to change. So the bigger the number, the more votes. So Guillermo, maybe while we're waiting for the audience to put in, what would be your answer to this question in terms of how many hours in the clinic are anemic patients spending, or transfusion-dependent patients spending?
At MD Anderson, probably it will take like 9 hours to get this done. But by the time you get your CBC performed, your type and cross, you get the product, etc. So, and the time it takes to transfuse these cells, at least 8 hours, if not more.
So it's a full day.
It's a full day. And remember, our patients are, at least the ones with MDS, are elderly. Houston is a big city, so you have to come here on time, get this. So you're basically here all day long doing this.
Yep, and that's what it looks like. The polling is also similarly saying 8 hours or so.
Do we click for the next question? Okay. So I think I'll start here. So I'm going to give you 4 or 5 slides, and I want to tell you from the beginning that I actually never got this right. So this took me maybe like 10 to 15 years to understand. Because in my mind, the anemia was kind of a consequence of the disease. So anemia per se had no value. What had value was like taking care of the disease entity itself, let's say achieving a complete remission or removing mutations or something like that. And as you will see today from, I hope, later on through the presentation and data that Valeria Santini presented at EHA and I presented at ASCO, we are starting to see that some of these newer agents, at least in low-risk myelodysplastic syndrome, they appear to be improving the survival of our patients. And these are drugs that actually don't kill the mutational burden of the disease. So basically, you're not attacking the disease per se, yet they may be influencing the natural history of the disease. So I think there is something more to, you have anemia and you are more fatigued and you may have some more cardiac issues. It's not such a direct, easy correlation. And I think this is actually one of our tasks to better understand actually what is the interaction between improving anemia, lower transfusion rates, and perhaps an improvement in survival in our patients with TGF-beta modulator like Luspatercept or with whatever many other therapies or combinations that we can come in the near future. So Basically, what we're starting to think is it possible that an early initiation of therapy may actually be the way to start thinking about this condition? So in these 3 boxes, you see some of the potential hypotheses for this. Of course, we're starting to talk about diagnosis of clonal conditions like CHIP, CCUS. Many of them are actually in the boundary of lower risk myelodysplastic syndrome. Question could be, does it make sense actually to start treating these patients? We're talking about transfusion dependency versus transfusion independency, right? So for many years, we will not act until the patient will become transfusion dependent. And actually, the threshold for transfusion dependency were quite stringent. We went through COVID then, right? I don't know in Europe, but here, at least in Houston, transfusion less than 7 grams of hemoglobin. There were no donors, no blood products. And then we started to see, and I always give credit to Dr. Maria Diaz-Campello in Spain, to this issue that with low-dose lenalidomide in transfusion-dependent del(5q), actually we're starting to see really potential strong disease modification. Again, you're going to think I'm kind of not that smart, but the first time I saw that presentation at ASH, I was like, why are they doing that, right? Like the first time this was presented, I couldn't get it. Like, okay, you have del(5q) minus MDS, you have good prognosis, why would you start any therapy? And then when we saw the final report of this last year, you see cytogenetic response rate 80%. These patients actually are transfusion dependent almost 80% of the times. And apparently, and data from Valeria also suggests that you could stop therapy at 2 years and remain transfusion dependent for a long period of time. This is as close as we have for TFR, kind of what they do in CML in myelodysplastic syndrome. Now, this is a small fraction of patients, but to me, it really opened the doors to start thinking, can we do that in other situations? And of course, we have the ELEMENTS MDS trial that is actually asking this question. What happens if we start intervening with an effective, safe compound like Luspatercept in these patients that are transfusion independent? We think this is actually very important. And now we go into this issue of, is it possible that this kind of intervention improves survival? Now, that was a secondary endpoint pre-planned on COMMANDS trial. But I think the questions are very fundamental, and I will be discussing them on Saturday in the kind of final summary of the SOHO. That is, if you have this kind of phenomenon with a response rate that is, don't remember, 60 to 70%, and a median duration of response, let's say 120 weeks, I'm making this up. And now you have some type of combination or some strategy where now you're responding 80% in terms of 60, or the duration of response now is 180 weeks in terms of 120. Is it possible that we'll start seeing actually a more clear effect in terms of outcomes of our patients? Now, that's very easy to say, but it's very difficult to do because it will be extremely complex, I think, to design a survival lower risk MDS trial with many years of survival. So we need to think about how we do that in MPN and how we do that in myelodysplastic syndrome. And I think as we evolve, how we design these trials, how we determine safety, efficacy, and so forth, will likely change. Now, this is something that I was saying at the beginning, that when I was first looking at this data, I never really understood it. The first time I saw a slide like this was in a meeting in Madrid, actually, with the MD Anderson Madrid, where Eva Helmstrom was talking about this particular phenomenon. This is many, many years ago. And I was like, okay, what is the point of this? You have MDS, you have anemia. If the anemia is bad, you're going to do worse. How can you do better, right? But I didn't put it together that you could actually kind of use that as some type of paradigm to really modify the disease. So the data actually is very clear as you see it here. So on the left, you see, for instance, that the survival is really directly correlated to the degree of hemoglobin. So in the purple, you have less than 10, 8 to 10 in the red color, and so forth. So there's actually a very dramatic difference in terms of the median survival of these patients, just based actually on a very simple factor that is baseline hemoglobin. And you said, well, that's obvious. You are very anemic. You may have more cardiac stress. There's a paper that just came out actually from European, I'm pointing to John, but I should point to Matteo, from one of these Horizon projects actually correlating the degree of anemia with the risk of infection in patients with lower risk myelodysplastic syndrome. So this may be actually a little bit more complex than just pathophysiology. What is interesting is the cause of non-leukemia death. So the very first paper that we published in the MDS section when it was formed around 10 years ago was cause of death in this disease. And cause of death in this disease in low risk is not actually progression to high-risk MDS or kind of per se leukemia death. It's actually death from complications of the low-risk MDS per se. So complications from the anemia, complications from infection, complications from bleeding. This is really important because it means that our goal in the past that was kind of abort transformation to high-risk MDS or acute myelogenous leukemia is important, but it's not the key. If we really want to change the natural history of the disease, we have to stop the disease from basically causing these complications. This is then translated into transfusion dependency, okay? Again, I couldn't get this at the beginning. The more transfusions you have, the worse it's gonna be. But it's actually a much more powerful correlation. And actually some of this data, Matteo, came from data from Pavia in the old days by Dr. Cazzola and his group. So basically you see here that those patients are very different prognosis and survival if they are transfusion dependent or transfusion dependent. Now, if you're here and you're an expert on this field, you know that how we define transfusion dependency has kind of changed over the years. Concepts that we didn't have before, like transfusion burden, that I believe started with Medalist trial. I'm not sure if I'm correct, but that's the first time I heard about low transfusion burden, high transfusion burden, are really starting to separate how we understand these patients. And this is actually sometimes more powerful, actually, than the genomic characteristics of these patients. So there is something intrinsic to the biology of the disease that is related to the anemia. Now, quality of life. Now, as opposed to what they do in MPNs, this is actually more difficult in myelodysplastic syndrome. And Esther Oliva has been a colleague of us in many meetings. I think she was also with us in Amsterdam. This is a little bit more complicated, and it's a question that always comes. Why we don't use a tool for quality of life in our patients in MDS? It's really heterogeneous, and I think it's extremely difficult to measure, but we could learn from you guys in the MPN field to see how we could kind of bring a tool like that in disease. Bottom line, our patients are not as symptomatic as your patients in terms of fevers, night sweats, weight loss, as we have in MDS. But it will be actually something extremely important to really understand. And then now we are in this era, and we're going to cover it today in quite a bit of detail, where we had a line of therapy that was with us for like 30 years. Actually, I was chief fellow in Philadelphia, and that was like the hottest drug ever, Poietin alpha. But now we have TGF-beta modulators, telomerase modulators. We may have JAK inhibitors, and we're really opening actually this field of potential combinations that could really change. So the question is, should we start moving from past therapies, like the ESAs were great for us for many years, but they've never really been approved in phase 3 trials. They don't really change the natural history of the disease. Are we in a position to say we have a very clear first-line therapy with a TGF-beta modulator, we have a second line, perhaps with a telomerase inhibitor? Should we actually start building on the data from COMMANDS into very powerful combinatorial type of approaches? So this will be the discussion today and actually tomorrow in the MDS section. So this is going to be really important. It may be actually a way, and I'm actually not being funny, by which actually we don't really have a job right now, because if we catch the disease early, we intervene with this kind of therapies early, and we can really abort the complications of this disease, it may be that the latency of these patients could be actually now measured not in years, but in potentially as close as decades, like if everybody were SF3B1 RS positive mutated. So it's going to be really interesting how the field moves in the next, I would think, few months or couple of years in terms of these new strategies in lower risk myelodysplastic syndromes. And with that, I'm going to pass it to John, who's going to tell us about his vision in myelofibrosis.
Okay, thanks, Guillermo. So, what always impresses me about these discussions is the fact that there are similarities yet distinctions between these diseases and the issues that surround anemia, both in MDS and MF. So, unlike anemia as a focal point of therapeutic intent in lower risk MDS, typically in MF, we're looking at anemia in higher risk patients. So it's a spectrum of patients where maybe it's not exactly the same goals of therapy. And MF does have some similarities, but distinctions from MDS. It's a disease that is characterized by cytopenias, could be anemia, thrombocytopenia, sometimes neutropenia, systemic symptoms that are driven by the inflammatory state, and then extramedullary hematopoiesis that drives organomegaly, particularly splenomegaly, which contributes to the disease burden and also likely contributes to worsening anemia. Patients with myelofibrosis have a lot of symptoms, and that's very clear. And I would argue that in MF, probably the most amount of work has been done by Ruben Mesa and colleagues in trying to understand the symptom burden, qualify it, quantify it, both as trying to appreciate what's happening with the patient, but also as a means of understanding what our treatments, particularly JAK inhibitors, are affording our patients. Anemia is a major issue in myelofibrosis. Almost 40% of patients will present with anemia. When I say that, a hemoglobin less than 10 grams per deciliter, and almost a fifth of patients will be transfusion dependent within the first year of diagnosis, and that worsens over time. And as we keep saying, this is a very symptomatic disease. Some of those symptoms are directly related to anemia, but not all the symptoms. And even patients who have significant anemia will have symptoms that I don't always think are necessarily linked or clearly linked biologically to the hemoglobin. And unlike MDS, although you can see fibrosis, a tenet and a hallmark of myelofibrosis is both reticulin and collagen fibrosis, which typifies this inflammatory state, mainly driven by TGF-beta and malignant megakaryocytes, but also contributes to the cytopenias. And many studies have linked the degree of fibrosis with the severity of the disease and the severity of the cytopenias. What we've failed to do in most trials is demonstrate that alleviation of anemia with antifibrotic therapies improves the cytopenias. What about the pathophysiology of anemia? Again, the obvious thing is to always say it is complex. I've never heard it ring before. That's interesting. It is complex, and what we're showing here from a paper from some years ago is the etiologies of anemia, which is both from poor production, fibrosis that likely obstructs normal hematopoiesis, leading to extramedullary hematopoiesis, aberrant trafficking of stem cells to other areas like the spleen and the liver, in which you have then ineffective erythropoiesis and hematopoiesis. And then the intensely inflammatory state that's driven by IL-8, IL-1, IL-6, TNF-alpha, and many other cytokines that also contribute to this inflammatory cytokine state. And then more recently, by work by Stephen O and others, and Aaron Gerds, who's sitting here today, is understanding the hepcidin axis in anemia, which is driven again by cytokines and BMPs, TGF-beta superfamily members that then lead to SMAD signaling and upregulation in hepatocytes of hepcidin, which is really an acute phase response protein that governs iron availability through ferroportin channels. So another mechanism that layers to the complexity of anemia in myelofibrosis, and not just in myelofibrosis, but today we're talking about myelofibrosis. And then unfortunately, most of the therapies that we've given historically, and many of the JAK inhibitors, will compound the anemia with therapy-related anemia. And when we get to the section with Prithvi and Aaron, we'll talk about whether that has significance in terms of outcomes when you see treatment-related anemia versus disease-related anemia. But from this slide, the take-home message is anemia is complex. It's a major burden to patients. And it gets worse with time. So as the disease progresses, anemia is basically a hallmark of the progression of disease. As the disease is worsening, the anemia, the frequency, the depth of anemia, the need for red cell transfusions worsens with the clinical course. And most patients eventually will be anemic with myelofibrosis, and at least half the patients within a year will need red cell transfusions. The Italians have done the most beautiful work looking at the significance of anemia in the setting of myelofibrosis and demonstrating from a cohort of patients in Italy this relationship between the depth of anemia and the outcome. So it's not just that anemia is a burden to patients, but it hallmarks the patients that are going to do worse. And the degree of anemia, as you can see here, the worsening survival. Severe anemia less than 8 grams per deciliter, a median survival of 2 years versus hemoglobins that are not reduced at that point, 7.9 years. And if you just simply dichotomize the patient, red blood cell transfusion dependent or independent, obviously those patients with transfusion-dependent anemia have a far worse and far poorer outcome. Again, other work done by Italian colleagues have also demonstrated that patients with myelofibrosis that have even one cytopenic feature, whether it's a white count less than 4,000, a hemoglobin less than 11 in a woman or 10 in a man, or platelets less than 100,000, having one of them puts the patient into a cytopenic profile, and we have now sort of segregated or put patients in the spectrum from cytopenic to proliferative. And the cytopenic patients here, you can see, have a worse outcome than the patients who have the proliferative form of disease. And the greater the number of cytopenias, the worse outcome, which I'm showing you basically here. So worsening cytopenias and worsening number of cytopenias also foretells a poorer outcome for our patients with myelofibrosis. So myelofibrosis is not only complex and has probably some similarities in terms of mechanisms to MDS, but it's also compounded by many of the therapies we give, has prognostic implication, and remains an important goal, an unmet goal for many patients, but alleviated with some of the newer therapies we have that we'll discuss in today's meeting.